Good morning, everyone. First of all, I would like to thank USI and Professor Anup for giving me this opportunity. Extent of lymphadenectomy in cancer prostate. What is adequate? Well, by now, all of us are pretty clear that lymphadenectomy is an integral part of prostate surgery, and almost all major guidelines, AUA, EUA, and NCCN recommends lymphadenectomy in intermediate and high-risk patient. The controversial reason is the extent of lymphadenectomy, which varies. So what should be the template for lymphadenectomy? Anatomical areas of pelvic lymph nodes are divided into 5 groups: obturator, external iliac, internal iliac, common iliac, and presacral nodes. There are quite a few different types of lymphadenectomy done in cancer prostate. The limited pelvic lymph node dissection, where only the obturator nodes are removed, the extended pelvic lymph node or the extended lymph node template, and the superextended lymph node template. All of them vary according to the extent and the numbers of lymph node groups removed. So, the limited pelvic lymph node dissection involves removal of only the obturator nodes. The standard one involves removal of obturator external iliac nodes. The extended lymph node dissection involves removal of obturator external iliac and internal iliac. Some people also consider it up to the crossing of iliac vessels. And the superextended involves removal of all the groups of lymph node, including the presacral ones. Sentinel lymph node dissection. The concept that the sentinel node is the first to be involved by migrating tumor cells, but heterogeneity and the variation of lymphatic drainage in cancer prostate varies. Of course, more lymph node can be found when sentinel lymph node dissection using ICG is combined during ePLND. But there was no major difference in biochemical recurrence rate, and insufficient evidence supporting sentinel lymph node biopsy exists now, so it is still considered to be experimental. So the major debate is between the limited lymph node dissection and the extended PLND. A very important paper published by Mortary, even though it's an old one, mapped the pelvic lymph nodes in cancer prostate. 34 patients were included in the study, clinical T1 and T2. The lymph nodes were mapped by SPECT, CT or MRI after injection of intraprostatic technetium-99. A backup ePLND was done to preclude any missed primary landing site. Based on this, 317 lymph nodes were identified preoperatively. Of these, 314 could be easily identified during surgery. But due to technical feasibility, only 300 lymph nodes could be removed. So we can see the group of lymph nodes. Around 38% were in external iliac and the obturator nodes. Around 16% were in common iliac and 25% in internal iliac. So based on this study, 75% of the lymph node can be removed when we are doing lymphadenectomy up to the iliac crossing, and only ePLND, the standard one, removes 63% of the lymph nodes. So complete removal is not feasible because of surgical and technical consideration. Thus, based on this study, if we remove all the lymph nodes up to the iliac crossing, 75% of the lymph nodes could be removed easily. Another important paper by Lestingi, which is a phase 3 trial, which have compared the extended versus the limited pelvic lymph node dissection during radical prostatectomy for intermediate and high-risk patients. Their early oncological outcome. It's a single center prospective trial. It's a phase 3 trial which involved 300 patients, intermediate and high-risk patients. 9 fields of lymph nodes were removed in ePLND, and one group of lymph node was removed in limited pelvic lymph node dissection. The endpoints were biochemical recurrence-free survival, and the secondary endpoint was metastatic-free survival and cancer-specific survival. The outcome of the study was, in patients with ISUP grade 3 to 5 undergoing ePLND, they had better biochemical recurrence. Another important study by Fossati, the benefit and harms of different extent of lymph node dissection during radical prostatectomy, a systematic review. It studied 66 studies and over 2,75,000 patients were involved. The main objective were assessing the relative benefit and harms of PLND for oncological and non-oncological outcomes in patients undergoing radical prostatectomy for cancer prostate. The outcomes were PLND and its extension are associated with worse intraoperative and perioperative outcomes. Direct therapeutic effect is still not evident from current literature. Still, PLND is justified as it assesses the accurate extent of the spread. A recent paper published by Tofir in 2021 comparing the limited versus the extended pelvic lymph node dissection for prostate cancer. It has concluded that there is no biochemical free survival advantage in patients undergoing extended pelvic lymphadenectomy as compared to the limited one. So the conclusion of this study was extended pelvic lymphadenectomy did not improve the freedom from biochemical recurrence over limited pelvic lymph node dissection for men with clinically localized prostate cancer. There were smaller than expected differences in the nodal count and the rate of positive nodes between the two templates. If you see the distribution of node positive patients undergoing ePLND, we can see that majority of the lymph nodes belongs to common iliac, external iliac, internal iliac and obturator. Only a small percentage belongs to presacral region. So we need not dissect the presacral region as it accounts for only 4% of the lymph. When the superextended lymph node dissection was compared with the extended one, an important paper by Hecky, it showed that superextended lymph node dissection have a lower chance of regaining both urinary incontinence and erection. So to conclude, PLND continues to be the most accurate staging tools. There are quite a few nomograms which can accurately predict lymph node invasions, but all of them are from pre-MP-MRI era. Lymph node invasion disease characteristics are key part of post-operative management in patients found to have lymph node invasion. ePLND provides better diagnostic but not necessarily improved therapeutic benefit to the patient. Thank you.